Hello everyone, welcome back to my channel. Let's learn about diabetes mellitus, its definition, signs and symptoms, types, causes and pathophysiology in a simple and easy way. Insulin is the main hormone that regulates intermediary metabolism, and its most important immediate action is to lower blood glucose levels by allowing glucose to enter the body's cells for energy. When insulin secretion is reduced or completely absent, blood glucose levels begin to rise. In many people, insulin may still be produced, but the body does not respond properly to it. This condition is called insulin resistance and is strongly associated with obesity. When there is either insulin deficiency or insulin resistance, or both, diabetes mellitus develops. Diabetes is rapidly increasing to epidemic proportions worldwide. Over time, persistent high blood sugar damages blood vessels and nerves, leading to serious complications such as atherosclerosis, heart attack, stroke, kidney failure, neuropathy, limb amputation, and blindness. Diabetes mellitus is a chronic metabolic disorder characterized by persistently high blood glucose levels, a condition known as hyperglycemia. It is diagnosed when fasting plasma glucose is greater than 7.0 millimoles per liter, or when plasma glucose exceeds 11.1 millimoles per liter 2 hours after a meal. Diabetes occurs primarily due to insulin deficiency, and it is often combined with insulin resistance, meaning the body's cells do not respond properly to insulin. Under normal conditions, insulin helps regulate blood sugar by reducing glucose production in the liver and promoting glucose uptake in skeletal muscles, where it is stored as glycogen. However, in diabetes, hyperglycemia develops because the liver continues to produce and release glucose uncontrollably, while skeletal muscles fail to take up sufficient glucose. At the same time, glycogen synthesis is reduced. This combination of increased hepatic glucose output and decreased peripheral glucose uptake leads to persistent elevation of blood sugar levels. Understanding these mechanisms helps us better appreciate the seriousness of diabetes and the importance of proper management. When blood glucose levels rise above the renal threshold for glucose reabsorption, the kidneys can no longer reabsorb all the filtered glucose. As a result, glucose spills into the urine, a condition known as glycosuria. The presence of glucose in the urine draws water with it, causing osmotic diuresis. This leads to excessive urination, or polyuria. Because of this fluid loss, the body becomes dehydrated, triggering intense thirst and increased fluid intake, known as polydipsia. At the same time, insulin deficiency has major effects on metabolism. Without sufficient insulin, the body cannot properly use glucose for energy. To compensate, it begins breaking down proteins and fats. Increased protein breakdown and reduced protein synthesis lead to muscle wasting and weight loss. One of the most serious complications of insulin deficiency is diabetic ketoacidosis, or DKA, which is a medical emergency. In the absence of insulin, fat breakdown accelerates, producing large amounts of acetyl-CoA. Since glucose cannot be effectively used in aerobic metabolism, acetyl-CoA is converted into ketone bodies, acetoacetate, beta-hydroxybutyrate, and acetone. Acetoacetate and beta-hydroxybutyrate accumulate in the blood and cause metabolic acidosis, while acetone contributes to the characteristic fruity breath odor. If not treated promptly, diabetic ketoacidosis can be life-threatening. Over time, diabetes leads to a wide range of complications due to long-standing metabolic disturbances. Many of these complications are related to damage of blood vessels. This damage can affect large blood vessels, known as macrovascular disease, or small blood vessels, referred to as microangiopathy. One of the earliest and most important events in the development of these complications is dysfunction of the vascular endothelium. The endothelium is the inner lining of blood vessels, and when it becomes damaged, it sets the stage for further vascular injury. Several mechanisms contribute to this damage. These include oxygen-derived free radicals, activation of protein kinase C, and the formation of advanced glycation end products. Advanced glycation end products are formed when excess glucose binds non-enzymatically to proteins like albumin. These harmful substances accumulate over time and disrupt normal cellular function, leading to inflammation and vascular injury. Macrovascular disease in diabetes is characterized by accelerated atherosclerosis, or atheroma formation. This increases the risk of thrombotic complications such as heart attacks, strokes, and peripheral vascular disease. These conditions tend to be more common and more severe in individuals with diabetes. Microangiopathy, on the other hand, is a distinctive feature of diabetes. It primarily affects small blood vessels in the retina, leading to diabetic retinopathy, in the kidneys, causing diabetic nephropathy, and in peripheral nerves, resulting in diabetic neuropathy. These chronic complications highlight the importance of strict glycemic control and early intervention to prevent long-term damage. Diabetes mellitus is the most common cause of chronic renal failure worldwide. Chronic kidney disease related to diabetes is a major and rapidly growing health problem. It places a tremendous financial burden on healthcare systems and deeply affects the quality of life of patients. Persistently high blood glucose damages the small blood vessels in the kidneys, leading to diabetic nephropathy. Over time, this damage reduces the kidney's ability to filter waste products from the blood. Coexisting hypertension, or high blood pressure, further accelerates this renal damage. In fact, hypertension and diabetes together significantly increase the risk of kidney failure. The good news is that proper management of blood pressure can slow the progression of diabetic nephropathy and also reduce the risk of cardiovascular complications, such as myocardial infarction. Among antihypertensive medications, angiotensin-converting enzyme inhibitors, or ACE inhibitors, and angiotensin receptor blockers, known as ARBs, are particularly effective. They not only lower blood pressure but also protect the kidneys. These drugs may provide additional benefits by blocking the harmful effects of angiotensin II and aldosterone, which contribute to fibrosis and progressive kidney damage. Now let's talk about diabetic neuropathy and the main types of diabetes mellitus. Diabetic neuropathy is one of the most common chronic complications of diabetes. It occurs due to prolonged high blood glucose levels, which damage peripheral nerves. One important mechanism involved is the accumulation of osmotically active metabolites of glucose. These are produced through the action of an enzyme called aldose reductase. When excess glucose is converted into sorbitol and other metabolites, they accumulate inside nerve cells, causing osmotic stress and nerve damage. Although aldose reductase inhibitors were developed as a potential treatment, they have unfortunately shown disappointing results in clinical practice. Now, moving on to the two main types of diabetes mellitus. Type 1 diabetes, previously known as insulin-dependent diabetes mellitus or juvenile-onset diabetes, is an autoimmune condition. In this type, the body destroys its own insulin-producing beta cells. As a result, patients require lifelong insulin therapy. Type 2 diabetes, previously called non-insulin dependent diabetes mellitus or maturity-onset diabetes, is the more common form. It is characterized by insulin resistance combined with a relative insulin deficiency. It is strongly associated with obesity, sedentary lifestyle, and genetic factors. Understanding these mechanisms helps in recognizing both the complications and the different forms of diabetes. Let's now discuss type 1 diabetes mellitus. Type 1 diabetes is characterized by an absolute deficiency of insulin. This occurs due to autoimmune destruction of the pancreatic beta cells, the cells responsible for producing insulin. Because the body produces little or no insulin, patients cannot survive without insulin therapy. If untreated, they will eventually develop a life-threatening condition known as diabetic ketoacidosis. Type 1 diabetes usually develops in children or adolescents, and patients are typically not obese at the onset of symptoms. Research has shown that genetics plays an important role. Studies involving identical twins suggest that individuals may be genetically predisposed to the disease. However, genetic susceptibility alone is not enough. An environmental trigger is also required. Viral infections, such as Coxsackie virus or echovirus, are believed to act as possible triggers. These infections may damage pancreatic beta cells and expose specific antigens, which then initiate a self-perpetuating autoimmune response. Interestingly, symptoms of diabetes do not appear immediately. The patient becomes overtly diabetic only after more than 90% of the beta cells have been destroyed. This long pre-diabetic phase offers a potential opportunity for early intervention. Various preventive strategies have been explored, including immunosuppressive therapy, early insulin treatment, antioxidants, and nicotinamide. Although results so far have been disappointing, research in this area remains highly active and promising. Understanding this process helps us appreciate both the seriousness and the complexity of type 1 diabetes. Now let's talk about type 2 diabetes mellitus. Type 2 diabetes develops when the body experiences both insulin resistance and impaired insulin secretion. Both of these problems play a critical role in the disease's development. Unlike type 1 diabetes, type 2 usually develops in adulthood and is strongly associated with obesity. The risk increases with age, partly because pancreatic beta cell function gradually declines over time. When patients first develop type 2 diabetes, treatment often begins with dietary modifications and lifestyle changes, such as weight loss and exercise. However, as the disease progresses, many patients require oral hypoglycemic medications to help control blood glucose levels. Ultimately, about 1/3 of patients with type 2 diabetes will need insulin therapy to maintain proper blood sugar control. Understanding both the insulin resistance and beta cell dysfunction in type 2 diabetes is key to managing the disease effectively. Pathophysiology of the diabetic state. Normal glucose regulation involves many factors including insulin, counter-regulatory hormones, incretin hormones, and amylin. Changes to any of these factors may result in an imbalance in glucose levels. 1. Insulin regulates the metabolism of carbohydrate, protein, and fat as follows. Promotes the cellular uptake of plasma glucose. Stimulates conversion of glucose into energy storage molecules, example, glycogen, fat, in the liver, muscles, and adipose cells. Facilitates cellular uptake of amino acids and their incorporation into proteins. Inhibits production of glucose from liver, muscle glycogen, or amino acids. Counter-regulatory hormones in diabetes are hormones that oppose the action of insulin. While insulin lowers blood glucose levels by promoting glucose uptake and storage, counter-regulatory hormones increase blood glucose levels by stimulating glucose production and reducing glucose utilization. The main counter-regulatory hormones include glucagon, stimulates the liver to convert glycogen into glucose, glycogenolysis, and to produce new glucose, gluconeogenesis, thereby raising blood glucose levels. Growth hormone, reduces glucose uptake by tissues and increases fat breakdown, contributing to elevated blood glucose levels. Catecholamines, epinephrine and norepinephrine, promote glycogenolysis and gluconeogenesis, inhibit insulin secretion, and stimulate glucagon release, all of which increase blood glucose. Cortisol, enhances gluconeogenesis, decreases peripheral glucose utilization, and promotes protein breakdown, leading to increased blood glucose levels. These hormones play an essential role in preventing hypoglycemia, especially during stress, fasting, illness, or exercise. However, in diabetes, excessive or unopposed action of these hormones can contribute to hyperglycemia. Incretin hormones are gut-derived hormones that enhance insulin secretion in response to oral glucose intake. When glucose is ingested, it stimulates a greater and more rapid insulin response compared to intravenous glucose administration. This phenomenon is known as the incretin effect. The incretin effect occurs because hormones are released from the intestines as soon as glucose enters the gastrointestinal tract, even before significant absorption into the bloodstream. The two main incretin hormones are gastric inhibitory peptide, GIP, also known as glucose-dependent insulinotropic polypeptide. Glucagon-like peptide 1, GLP-1. These hormones are secreted in response to nutrient ingestion and act on the pancreas to enhance insulin secretion in a glucose-dependent manner. In diabetes mellitus, DM, particularly type 2 diabetes, postprandial secretion of GLP-1 is diminished. GIP secretion is normal or may be increased, but its insulinotropic effect is often reduced. The actions of incretin hormones include increasing glucose-dependent insulin secretion, inhibiting inappropriate glucagon secretion, increasing beta cell growth and replication, slowing gastric emptying, suppressing appetite. Overall, incretin hormones play an important role in postprandial glucose regulation, and their impaired function contributes to hyperglycemia in diabetes. Amylin. Amylin is a hormone that is co-secreted with insulin from the pancreatic beta cells in response to food intake. It works together with insulin to help regulate postprandial, after-meal, blood glucose levels. In individuals with type 1 diabetes mellitus, T1DM, there is little to no amylin production because the beta cells are destroyed. In type 2 diabetes mellitus, T2DM, amylin is still produced, but often in insufficient amounts relative to the body's needs. Amylin lowers postprandial blood glucose levels through the following mechanisms: prolongs gastric emptying time, slows the rate at which food leaves the stomach, leading to a more gradual absorption of glucose, decreases postprandial glucagon secretion, reduces the inappropriate release of glucagon after meals, which helps prevent excessive glucose production by the liver, suppresses appetite, promotes satiety, reducing food intake and contributing to better glucose control. Overall, amylin complements the action of insulin in maintaining postprandial glucose balance. Development of diabetes mellitus 1. Type 1 diabetes mellitus, T1DM, type 1 diabetes mellitus, T1DM, develops as a result of a combination of genetic predisposition, environmental triggers, and autoimmune mechanisms that lead to progressive destruction of the pancreatic beta cells. In genetically susceptible individuals, environmental factors such as viral infections or other unknown triggers may initiate an autoimmune response. The immune system mistakenly identifies the beta cells of the pancreas as foreign and gradually destroys them. T1DM is therefore an immune-mediated disease characterized by progressive beta cell destruction, absolute insulin deficiency, dependence on exogenous insulin for survival. As beta cell destruction progresses, insulin production declines until it becomes insufficient to maintain normal blood glucose levels. Once most beta cells are destroyed, patients develop abrupt onset of clinical signs and symptoms, which may include polyuria, frequent urination, polydipsia, excessive thirst, polyphagia, increased hunger, weight loss, fatigue. Without insulin therapy, individuals with T1DM are at high risk of developing diabetic ketoacidosis, DKA, a life-threatening complication. Thus, type 1 diabetes is primarily an autoimmune disorder resulting in absolute insulin deficiency and rapid clinical presentation. A. Genetics. Genetic susceptibility plays an important role in the development of type 1 diabetes mellitus, T1DM. However, genetics alone does not fully explain the disease. Studies of identical twins show approximately a 50% discordance rate. This means that if one twin develops T1 German mark, the other twin has about a 50% chance of not developing the disease. This finding suggests that, in addition to genetic predisposition, other factors, particularly environmental influences, are necessary to trigger the condition. The risk of developing T1DM is also increased in the offspring of individuals diagnosed with diabetes, further supporting a hereditary component. B. Environment. Environmental factors are believed to act as triggers in genetically susceptible individuals. Suspected environmental triggers include viral infections, such as rubella and Coxsackie B virus, chemical exposures, dietary factors, such as early exposure to cow's milk. These factors may initiate or accelerate the autoimmune process that leads to the destruction of pancreatic beta cells. Together, genetic susceptibility and environmental triggers contribute to the immune-mediated destruction of beta cells that ultimately results in type 1 diabetes mellitus. Autoimmunity. An autoimmune component, possibly triggered by an environmental factor, is involved in the development of T1DM. Anti-insulin or anti-beta cell antibodies are present in the blood of most individuals at the time of diagnosis of T1DM. Antibodies to glutamic acid decarboxylase, GAD, are found in the blood of approximately 70% of individuals diagnosed with T1DM. Thus, the presence of these antibodies may serve as an immunologic predictor of the future development of the disease. 2. Type 2 diabetes mellitus, T2DM. The development of type 2 diabetes mellitus, T2DM, is multifactorial. It involves genetic factors, beta cell dysfunction, and peripheral tissue defects, insulin resistance. A. Genetics. Genetics plays a major role in the development of T2DM. Studies of identical twins show a greater than 90% concordance rate if one twin has T2DM. This high concordance strongly suggests that T2DM is predominantly influenced by genetic factors. Additionally, the risk of offspring developing T2DM is at least 15%, and this risk increases further if both parents are affected. B. Beta cell dysfunction. A primary beta cell dysfunction is believed to be a key factor in the development of T2DM. At the time of diagnosis, typically only about 50% of pancreatic beta cells are functioning. This reduced beta cell function leads to insufficient insulin secretion relative to the body's needs. As the disease progresses, the number and function of beta cells continue to decline, resulting in worsening hyperglycemia over time. C. Peripheral site defects, insulin resistance, peripheral tissue defects also contribute significantly to T2DM. In this condition, target tissues, such as muscle, fat, and liver, do not respond properly to insulin. This is known as insulin resistance. Possible mechanisms include defects in postreceptor insulin signaling, a decreased number of insulin receptors. These abnormalities impair glucose uptake by cells and increase hepatic glucose production, ultimately leading to hyperglycemia. 3. Secondary diabetes. Secondary diabetes refers to diabetes that develops as a result of another underlying medical condition or as a consequence of certain treatments or medications. Unlike type 1 and type 2 diabetes, which are primary disorders of insulin production or action, secondary diabetes occurs when another condition interferes with insulin secretion, insulin action, or both. Causes of secondary diabetes. Secondary diabetes may arise from 1. Other medical disorders. Cushing's syndrome, Excess cortisol increases blood glucose levels. Acromegaly, excess growth hormone causes insulin resistance. Cystic fibrosis, damage to the pancreas impairs insulin secretion. Down syndrome, associated with increased risk of autoimmune and metabolic disorders. Pancreatic disorders, such as pancreatitis, pancreatic trauma, or pancreatic cancer, which damage insulin-producing beta cells. 2. Medications and treatments. Certain drugs can impair insulin secretion or increase insulin resistance, including glucocorticoids, increase hepatic glucose production and cause insulin resistance. Antipsychotics, particularly some atypical agents that promote weight gain and insulin resistance. In summary, secondary diabetes develops due to identifiable underlying conditions or treatments that disrupt normal glucose regulation. Management typically involves treating the underlying cause along with standard diabetes care. Disclaimer: this video is for educational purposes only. It is not intended to replace professional medical advice, diagnosis, or treatment. Do not self-medicate with vitamins or supplements based on this video. Always consult a qualified healthcare professional before making any changes to your diet or supplement routine. Thank you for watching. If you found this video helpful, don't forget to like, share, and subscribe for more simplified pharmacology and exam-oriented medical content. And make sure you press the bell icon so you never miss an important update. See you in the next session.